Hello, everybody. Main focus during this lecture will be the physical assessment and the health history. Okay. There's a lot of overlap in these components, obviously, with the adult world. So I'm mainly going to be highlighting the differences. And then in future lectures, like the health promotion lectures, we're going to go into more specific developmental milestones and what you would be looking for, as well as nutritional development during childhood for each of the age groups. So we're really focusing right now on health history and physical assessment. One of the key components to any assessment is communication, especially for pediatrics. You're obviously working with the parents or the caregivers as well as the patient. So when you're working with a patient, you always want to encourage the parents to talk. Obviously, a nonverbal child like an infant or a developmentally delayed child won't be talking anyway, but those school age kids may try to run the conversation. But the parent is really your main source of information. And so encouraging them to talk and making sure that they are comfortable is very important. What is also important is directing the focus of the conversation so that it doesn't take all sorts of sidetracks. You might be in there all day if you let them ask all the questions that they have about their child. So we need to be specific in our questions, but also allow for them to kind of ramble. And so it's a very special balance. And you'll know immediately if you're getting off track and you'll kind of where to rat and you can go back and try it again. It doesn't, hurt anything to let them talk, especially as a student when you have the time, but just be aware that parents like to talk about their kids and it's not always relevant to the questions that we're trying to answer. We also want to be very culturally aware of how our families may deal with different issues, how they typically raise children, and cultural aspects that are involved in all of that. Always being empathetic to their concerns. We never want to dismiss a parent's concern. They do know their child better than we do. So we also want to continually provide anticipatory guidance to parents. And what does this mean? This means that if the child is 5 and we are dealing with an issue at the age of 5, we also want to be educating that parent on what to expect in the next year or two. This is very important in infancy when there's a lot of rapid growth. Obviously, milestones happen quite frequently in that age group, not so much in the school age, but that anticipatory guidance is still very important. For example, when my kids go and have their well child checkups, we're always talking about safety. He always says, there's wheels on the feet, there's a helmet on your head, and things like that. And so it even not even just developmental anticipatory guidance, but also education that relates to whatever their problem is when they're in the hospital would be applicable as well. When you communicate with children, you always want to make sure that your communication is developmentally appropriate. And I think this is the hardest thing for students to grasp and the most intimidating thing. And also really the biggest difference, right? Because anatomically, children and adults have the same parts, but the way that you approach that assessment with them is what's going to be different. So you want to be aware of where they are in their ability to communicate, how much they're able to communicate with you, and also to be really cognizant of your own nonverbals. They're very sensitive to nonverbal communication. You want to be relaxed and calm, even funny. All of those things can really help when you're trying to talk to and develop rapport with a child. So moving on to the components of the assessment. Most of this is pretty familiar to you, so I won't, drag on about it, but it's important to note the pediatric health histories are shorter in some areas and longer in others. They tend to be shorter in their medications, and their medical and surgical history, but then things like prenatal and birth history is not something that we think about asking a 40-year-old patient. It's not clinically relevant if they were a C-section or not, right? But it does matter for a 6-month-old. We also want to know about maternal health during pregnancy. Was there any drug use, any smoking, any diseases like gestational diabetes or an infection that might be affecting the child? We want to consider issues and complications during delivery and what the infant's condition was after birth. So my general rule is usually if the child's under 2, I still want to know the birth history because I want to know what might be contributing to the current situation with that child. Usually after the age of 2, it becomes less clinically relevant and we don't pay attention to it quite as much. Getting information about parental behaviors and emotions, they can also be distracted during the health history depending on the child. Most kids don't want to sit through a boring adult conversation. Even my school age kids that are 10 and 7 um, really don't let me talk to another adult when I am trying to talk to their PCP. So it can take a long time. It can be more difficult. Sometimes other strategies need to be utilized. So now onto that physical assessment component, okay? I want you guys to think about how this is going to differ from adults because students really get caught up on this. They get really intimidated, especially with infants, about doing a physical assessment. And I always tell my students in clinical, the body parts are the same. The anatomy is the same. They have a heart, they have 2 lungs, they have a stomach, they've got legs and arms. And so you're assessing the same things. Your difference is really going to be in your approach and sometimes in your order. If you remember back to your med surg rotations, you were able to go into the room with maybe you started with a list and you could literally just go from head to toe and tick through your little organized list of all the things you wanted to assess and get it done and breathe a sigh of relief and walk out. And you have this beautiful head to toe assessment that you did in 10 minutes or less, right? Peds doesn't let you do that because kids are going to be on their own schedules and you're going to go into the room and you're going to find that maybe some aspects of the assessment are a little bit more disruptive at that time. So you really need to be comfortable doing things out of order and remembering what you need to get done. And I think that's where the biggest lift is for students is being comfortable with change and being comfortable with not being able to do it all at one time. Even before you touch the patient, you could do a lot of your assessment before you even make contact with them. And sometimes that can be helpful. It's totally appropriate to do your physical exam on the parent's lap, for example, if that's easier for the child. You want to stay at that child's level as much as possible. That's crouching, sitting, kneeling. And that makes them feel a lot more comfortable. It makes you appear more approachable. Everybody likes that kind of bedside manner. I think that works in the adult world as well. Okay. And we'll talk more about physical assessment in a little bit. So for developmental history, we're thinking about things like what milestones have they accomplished? When did they accomplish them? How is their sleep? It prompts growth and development, but also parents care a lot about sleeping. If the child's not sleeping, the family's not sleeping. So that's a very common conversation. And it's a very big part of the health history. Nutritional history is important for everyone, but kids are growing and developing very rapidly. And so their needs do change over time. How they eat and what they eat changes. It's important for babies to find out if they're breastfed or formula fed. When they started solids, have there been any reactions to foods? And then following that, elimination is obviously very important, especially for nonverbal infants and toddlers who, can't tell you if they're thirsty. So we need to know how many wet and dirty diapers they're having a day, whether or not they're toilet trained, that kind of information. So we're going to move on to the physical assessment. Okay. The general approach is you want to gather as much data as possible by observation at first. And then you want to think about where that child is going to be in the bed, on their parent's lap, playing on the floor. Are they in a swing or a bassinet? That can be really intimidating for students sometimes to walk into a room and the kid's in a swing and they're like, I don't know how to get around this child. But you can do it, right? You just have to be flexible and you have to be open to doing things differently than you've done them up until this point. But you want to start with the least distressing part of the exam and end with the most distressing. So do the things that are least invasive first. Distraction is a very valuable tool. Anything that you can use to distract them, give them something to play with, let them touch things, let them be an active participant in the assessment. If it is age appropriate, that will absolutely help you as well. In the hospital, it's awesome because most of these kids have been assessed before you've gotten there. So it's not like you're going up to this kid for the very first time and they don't know what any of the equipment is. I think a lot of students live in a bubble where they feel like they're the first ones in the room ever and they're the first ones to show them a stethoscope and they're the first ones to take their blood pressure. And you guys aren't. And that is a huge advantage because you don't usually have to explain everything and deal with the fear with these kids unless they're 18 months old. And then it's new every time and you're just going to have to go with it. But 18-month-olds hate everybody. So just accept that and work around the crying and the screaming and the no-no-nos and you'll be just fine. Okay. You want to be honest with kids. If it's going to hurt, let them know in a calm fashion. If you lie to them, you will lose your credibility. And then, understanding those developmental stages. Stranger anxiety is a normal stage of development. So a previously cooperative child may be more difficult. I always tell students that I want the kid to be sassy and fight. Okay. Because a kid that is willing to put up a fight when they're faced with something they don't want to do is a kid that's pretty healthy. It's the kids that lay there when developmentally they shouldn't that concern me. So I think that that's an interesting perspective to take when you're feeling nervous and to understand that some of those responses are absolutely normal, even though they're uncomfortable to you. And it's your job just to come to terms with it and to work around it. And that's part of the practice that pediatrics gives students. So vital signs, we're going to do in a different order in peds, thinking about least invasive part first. Okay, we want to start with observation. You can do respiratory rate from the doorway sometimes, especially if that kiddo isn't swaddled up. You can see that respiratory rate. Then you'll move on to the heart rate, which I normally recommend you do while you're doing kind of your major parts of your assessment because you're already using your stethoscope on their chest. And so you can just move through and listen and do all your auscultation in that area and then end everything with the blood pressure and the temperature. Babies hate thermometers. I think it's mostly just the restraint of their arm, but they can't stand it and it makes them upset. And so if you get a child upset at the beginning of taking your vitals, all of your vital ranges are going to be abnormally high. So keep that in mind that they're going to cry and they're going to scream. And it's not necessarily a pain response, it's an anxiety response or a fear response. And you have to let them calm down again before you chart that something more significant is going on. Focusing on the involved system is also a really good strategy. Go in there and know that, if this kid's in there for a GI problem, make sure to get that GI assessment done first, okay? You don't need to do a full head to toe right away if you can't get to it. You can get the important things done, you can get your baseline, and then you can fill in the blanks later on. Developmental norms, obviously, again, are going to keep coming up, but you need to know if that child is acting abnormally. Okay. You need to know if they're having any changes in behavior, which could be neurologic in origin. You want to know the norms so that you can use appropriate approaches to get information and compliance and cooperation from that child during the exam. So another assessment consideration is stress, right? This is a very stressful environment for the child and for the parents. This often is the biggest concern for students when I think interacting with adults in the pediatric setting, because these aren't only family members that are a little bit sort of distanced from what's going on. These are their children. And so parents can be very tired and very stressed out. You don't know what's going on in their life, if they have other kids at home, if they have childcare taken care of. The kiddo has been pulled out of school and sleeping in an environment that they're not familiar with. So, I mean, stress everywhere. And understanding that and empathizing with that can be huge when working with peds, because it really colors so much of your interaction and so much of the behaviors that you might see. So, how do we mitigate it? Well, we can provide a warm room, warm blankets. Okay. We can let them stay in their own clothes sometimes, making sure that someone who's familiar to them is at the bedside, especially toddlers and older infants who are in that stranger danger part of their lives. They just don't like new people. And so there's not a ton you can do about that, right? They will cry, but you can make it easier for them by ensuring that somebody familiar is at the bedside, maintaining consistent caregivers, that sort of thing. Children really want to be in control of their body. And when you're in the hospital, you are not, right? Things happen when they have to happen. So you need to be able to give them some choices because they lose a lot of that control. And so an example of this would be if you're taking their blood pressure, saying, do you want me to use your right arm or your left arm? They're still going to get the blood pressure taken, right? But they get to control where you take it. And they might still say no. I mean, that's totally normal, but you do have to get it done, but you're trying to give them some sense of control there. Or you could say, should I listen here or here, heart or lungs first? And letting them make that choice, that can go a long way to getting cooperation from them. But we mainly just want that interaction to be as minimally traumatic as possible. Okay. Atraumatic care is another huge key term in pediatrics. Things will be traumatic and we can't avoid it, but we can do things to mitigate that trauma and to make it, you know, the best experience that it can be given the circumstances. Okay. So we have talked about the order of the exam. We are going to interact with those parents first and the child second. Okay. I kind of went through most of this already, so I'm not really going to linger on this too much. So, tips for cooperation. I'll usually make a complimentary remark when I go in there. It's the easiest thing to do, right? If they have a shirt on that has a character on it, or there's a toy at the bedside, or there's a show, usually there's a movie on. And I will generally, if you go in with me to see a patient, I'm like, oh, you're watching Moana. This was such a good movie. And sometimes they'll just kind of nod at you, but other times they will open up and start talking. It can be a really great opportunity to open up that rapport. You can tell a funny story to an older child. Like I said, most of these kids have been assessed before, so you don't need a full repertoire, but you do want to connect with them and really make that a focus of your clinical experience. I think it's a really good thing to practice in this clinical that is generally not as heavy and task-based and high acuity as some of your other clinicals may have been, is to really work on your communication skills and work on getting comfortable with talking to patients beyond why they're there and really seeing them as a whole person and letting them see you as a whole person. I think that can be a really rewarding experience at the bedside, and I highly encourage my students to work on that. If the child is just refusing to cooperate, you can ask the parent or child what has helped before. Especially this works well with like medication noncompliance. If the kid simply won't take the dropper with the medication in it, I will always ask the parent what they've done before to make that easier. And if it's a developmentally appropriate response, like a toddler that's just saying, no, 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 you just have to do your best and do it as quickly as possible to minimize distress. Be firm and direct about things that need to happen. These kids do love boundaries and routine. And so even if they don't want to do it, giving them that structure can actually be helpful. It's just, you have to be really careful about your tone and don't be like really crass and raise your voice, but be like, we need to get this done right now. When I'm finished, you can go back to watching your movie. I'll leave you alone for a while, but we're going to get this done so that we can make sure that you're healthy. And then, you prioritize those important things, like I said, and just come back later. So we already talked about positioning. I'm not going to really go over this very much, but this has some pictures of, showing a little kid who's practicing on a teddy bear. We're seeing a swaddled baby in a bassinet who looks very cozy. And then this other little kiddo is in a comfort hold with his mom for what looks like a vaccine. And that helps too. Sometimes even just for assessing, that can help a child feel more comfortable with the exam. Well, so let's talk about the peds vital signs. Okay, this is everybody's favorite. It's so fun to memorize. I recommend you bring a card with normal vitals to clinical. You're going to have to know it at some point, but for clinical, have a quick kind of index card or something that you can refer to. It'll make it really easy for you to kind of know what to look for before you go in the room. We do count the respiratory rate and the heart rate for a full minute in pediatrics. The normal range will change with age, but it also fluctuates from second to second. So it's really important to count it out. That full minute is really important. Baseline will change with age. Same thing with blood pressure. As far as your temperature, there's lots of different ways that you can take temperature. Tympanic is in the ear. Rectal is really what we prefer for infants, but we rarely do them at the hospital unless it is ordered. We'll usually use axillary. Okay. And you can use that route for almost anybody. We'll shift to oral once they can do it correctly. But honestly, even a teenager that's asleep at 2 a.m, I've done axillary temps on. If we're not concerned about an active fever and like the accuracy of the temperature isn't as important, you can use either routes. They are both evidence-based. They are both accurate. You don't have to stress about, oh my gosh, there's a 7-year-old and he keeps rolling it around in his mouth, but I can't do an axillary. You absolutely can. Okay. When in doubt, do the axillary if you're not sure. We also have different pain scales. And I think I'm going to talk about that here in a minute. There we are. So there's many different pain scales based on the patient's age and their developmental level, if they're awake, if they're unsedated. The main ones that you're going to see in the hospital is the FACES scale and the RFLAC, and then the visual analog, which is your number scale. The neonatal scales I'm not going to dwell on, just be aware that they are there. The RFLAC scale we can use on anybody from 0 to 3 and anybody who is nonverbal. So this uses nonverbal communication and sort of things like their face, their leg, their consolability. I'm trying to remember activity, cry. Okay. Face, legs, activity, cry, consolability. That's what it is. So it's an acronym. And then you can read the various descriptions of those things, and then you assign them a number based on those findings. And the higher score, the more pain they're in. The revised FACES scale, you can use at school age, but I again have used that with teenagers too. Carl has an image of this on the whiteboard, and there's a visual sort of reference for you, and you can just point to it and the kids can assign a number. We're going to monitor growth very, very closely in pediatrics. I think I talk about this more in the next lecture, which obviously I haven't recorded yet. A measurement of growth is a key element in evaluating a child's health. Infants and children are constantly growing, and some periods are more rapid than others. So the change in growth in the first year, tremendous, right? And we're always monitoring for too much growth or not enough. I'll show you how to plot growth on a growth curve. So that way, when you hear parents talk about how their child is in the 50th percentile for height, it's because it's plotted on a grid that compares them to the general pediatric population. So the growth parameters we look at are weight, height or length, and head circumference. Length is obviously usually up till 2 when we would measure a child laying down. So that's their length, but that just turns into their height when they're vertical and they're standing up. It's best to use a stadiometer for that. And that's the little thing against the wall that has like a little lever piece that moves up and down, and you have the kiddo stand up behind it and you put it to their head and then it lines up. It's basically a stand-up measuring tape, but we call it a stadiometer. We would chart that on a growth grid. Okay. The growth chart is a series of percentile curves that demonstrates the distribution of body measurements in children. And we'll kind of see what that looks like later. Family assessment, we're going to talk about really quickly about how it's different in pediatrics. The relationship between the child and the family members is a huge factor in their emotional and physical health. So collection of this data of the composition of family relationships among family members is important. It's important to keep in mind that family may look different for everyone. Okay. It's not always what we typically think of as a nuclear family, which is mom, dad, and children. So we should be asking, who is in your family? Who's part of your life? Who lives in the home? Who's part of the child's family? It is very important even when you go to the bedside in the hospital because it's not always the parent or the primary caregiver at the bedside. Sometimes it's aunt or grandma. I've had students walk in and, say, "Hey, mom," to a grandparent, or say, "Are you grandma?" to someone who is the mother. It can be very embarrassing, right? I had another student just last semester who went into a room and the boy was by himself. And so she was like, "Oh, are your mom and dad at work?" And he's like, "Actually, I have two moms." And she was devastated. She was so embarrassed. And the kid was just like, no big deal to him. But, she recognized that her approach to that was probably not worded the best way. And so just being sensitive to how we ask about the family composition is really important. This over here on the right is a family pedigree. It's much more related to genetic history and relational history of the family, but it's important for not for inpatient necessarily, but just for overall health to kind of understand about 3 generations back so that we're aware of any genetic conditions and patterns of inheritance so that we can be prepared for anything that might affect that child. A few more things to consider before we wrap up. We do want to know where the family lives, what that community environment is like. For young children, lead exposure is really important. So knowing the age of the house that they're being raised in so that we can monitor for lead if that is a high risk factor. Understanding that, child may not be safe at home and figuring that out. What the occupational and education level of the caregivers, any cultural or religious traditions that are important. You can also do a functional assessment of roles. So, like who plays what roles in the family. This isn't something, again, that you would do in the inpatient setting, but in outpatient clinics, this is very important. Okay. And that wraps it up. Join me next time for growth. We're talking about growth. All right. See you guys.